Hi, everyone. My name is Dr. Amy Taylor, and I'm an assistant professor with the Earl E. Bakken Center for Spirituality and Healing. And I'm a physician who's dual board certified in emergency medicine as well as integrative medicine. And I'll be your host tonight for Mini Medical School, Food, Nutrition, and the Effects of Substances on Health. We're really excited to have you here again tonight as we guide you through our second topic, Your Questions Answered, Cannabis, Psychedelics, Opioids, and Alcohol. We do hope that you were able to join us for last week's session, which we discussed various topics on nutrition, food insecurity, and environmental health. If you weren't able to join us, you are able to view this on our YouTube channel. We'll begin with a moderated discussion followed by a question and answer series. Please note that you can submit your questions at any time using the Q&A button located at the bottom of your Zoom screen. We will be recording today's session, and it will be available on our YouTube channel on the Office of Academic Clinical Affairs. You'll be sent a link to this in your email. All right, well, let's go ahead and begin. We have a really wonderful panel of experts tonight who are going to be discussing different substances, their potential health impacts, medicinal and recreational usage, and substance use disorder. I'm going to introduce our first panelist now, Dr. David Ferguson. Dr. Ferguson is a professor in the Department of Medicinal Chemistry at the College of Pharmacy. His research is focused primarily on using chemistry to solve issues related to the structure, function, and activity of molecules in biology, especially in the context of designing and finding new drugs. His research on opioids helped create the first blueprints for designing better and more specific drugs that can either activate or block their effects. He is well known for his innovative course on drugs of abuse that tackles the most difficult issues related to substance abuse in the community. Dr. Ferguson, welcome. Can you please discuss the effects of opioids and touch on psychedelics and their impact on health and the community?
Yes, thank you, Amy. And this is a great event. I'm really happy to be here. And covering these two, and they're really contrasting substance use, potentially disordered compounds. So let's get right into it. You've introduced everything that they need to know about me. We've had many guests in our classroom over the last 2 decades, from legislators to clinic directors, and we also invite many guests that are suffering from substance use disorders. So, we've taken in a lot of information over the last 2 decades, and it's great to be able to present some of that here. So let's just get going here. So first, I want to mention that the 2 compounds, or the 2 classes I'm going to talk about, are derived from natural products. So opium poppies, morphine, and ergot rye fungus, LSD. Morphine is sort of the quintessential opioid that most are derived from and even mimicked in terms of designer drugs. And then also, LSD is the quintessential psychedelic that is derived from the rye fungus, and it's a semi-synthetic. So if we look at the physical effects on the human body and psyche, I have to add psyche here because psychedelics, really do have a tremendous impact on the psyche. And let's just start over there on the right side with those, though. So psychedelics in general, it's mind, mood altering. People report spiritual experiences, associative creative thinking, altered perception, though I have to add in there. But the things in black are what people would recognize as desired outcomes. If you look to, the undesired outcomes, it can occur from constant use or possibly once it becomes a disorder and people are dosing more, using more, often paranoia, fear, confusion, flashbacks, psychotic episodes. Some people have life-altering experiences when these drugs are used. And also there is some development of tolerance. So these compounds are serotonergic agents, and they act through the serotonin receptor. And of course, that's a well-known receptor that affects mood. It affects things like empathy, how we feel about others, our closeness. And it's a mind more of a soul type of an effect that you have to keep in mind when people seek psychedelics. With opioids, often, of course, they start with a need for pain relief. And the desired effect for those that would use opioids is pain relief, but also euphoria. Opioids have this unique ability that not only do they relieve pain, but you feel great. And that's part of sort of the problem with their use. So the things you don't want to see, but we know that occur with opioids is physical dependence, tolerance, you need to increase dose, respiratory depression, constipation, drug-seeking behaviors. And of course, opioids act through the opioid receptors. And I want to point out one thing that's important here is you can't separate the opioid from the opioid receptor. And it's triggering that receptor that leads to the pharmacology and the cascade of events that cause the unwanted side effects. The same is true with the psychedelics. You can't remove the serotonin receptor from the equation. These are triggering that receptor, and that has a consequence. And that can't be changed without some type of intervention. So let's move to some of the compounds we're talking about. So everybody, we're going to talk about these. And if you have questions, this is a good starting point for some basic compounds. Morphine, and then of course the semi-synthetics, hydrocodone, oxycodone, oxymorphone, and those historically, of course, if you look at the opioid crisis, those sort of started the crisis in diversion and people essentially, becoming somewhat dependent on those compounds from, after surgeries or after dental work. And this escalated. And that was, I think, the first start of what we consider to be the epidemic or the opidemic in the US. And then we have fentanyl, which is a synthetic, and then the really potent compounds like sufentanil and carfentanil. Of course, fentanyl is about 100 times more potent than morphine, and that's why it's so dangerous in the community. And most of us know, we see it in the news every week, another death, a possible overdose, or a drug bust where fentanyl is found at the site. I want to point out that methadone and buprenorphine, Suboxone, these are also opioid agonists. So they trigger the opioid receptors, but they're used in maintenance therapy. So they are agonists. And then we also have antagonists, which most people now know from the billboards. Narcan is now Loxone. It blocks or displaces the opioid ligand from the receptor, and people really sit up, right? They're in deep respiratory depression. These have a tremendous effect, but the person also goes into significant distress due to that lack of that triggering of that receptor. In other words, that's that dependence piece that kicks in, that withdrawal piece that kicks in quickly. And then we also have naltrexone, and that's used sometimes for therapy to get off of substances and used for substance use disorder treatments. If we look at psychedelics, the classic is LSD. Of course, now mushrooms, psilocybin's making this great surge now in the US. And mescaline and peyote has always been one of the psychedelics in the US that's been used. It's a sacrament, but it's also capable of producing the spiritual spirit walks, things like that are associated with psychedelics. Most people don't remember, that psychedelics were also in the designer drugs back in a decade ago. The 2C compounds triggered many deaths across the country, and they were part of the legislation, but those are synthetic psychedelics. And then we have to add ecstasy here, because while it's not a hallucinogen, and I don't know if I classify it as a true psychedelic, it's thrown in this group because it's an empathogen, an entactogen, and it has similarities in triggering the serotonin receptor. So I want to point out something that's important for the audience to understand, and that is that when we use maintenance therapy, we are still triggering the opioid receptors. And I don't want to use the term dependence on it, but in rehabilitation and treatment, these are essentially keeping a threshold of activation that sort of satisfies that need, that helps with withdrawal and staying off of, let's say, drug-seeking behaviors. And I should point out that for psychedelics, there's nothing FDA approved. So I want to finish on just two things. And first, let's talk about opioids. And this is something we do, of course, in my classroom that's important for all of us to think about because it's all of us that make the change, right? And when we think of opioids, what do we think of first? Do we think of therapy? Do we think of, pain management? Most of us, including our young practitioners that are in my classroom, they think of the crisis. They think of overdose. They think of trafficking. They think of interdiction. They think of intervention, right? And my point about this is that, this is a really old frontier. It dates to 2000, 3000 BC, right? This is an old problem. And over the last, I think, 5 decades in the US, we've really defined this problem of what it is we have to do to solve it. Unfortunately, we haven't solved it. And I'm one that I've searched for the Holy Grail myself in terms of chemistry to come up with agents that could treat dependence, could treat disorder that were not addictive. I'll use the term addictive, that didn't produce dependence, or that could essentially cure. But we haven't accomplished this. And just to drive that point further home, this is Time magazine from 1973. And heroin, of course, was a global problem. We're 5 decades removed. And what's in the magazines today, right? We're still there. And it's such a challenge. But let's move to psychedelics. So when I ask a young student, aspiring clinician, what do they think of when I talk about psychedelics? When they see the title of my lecture, most will say, well, LSD, the 1960s. Many will say music, creativity. Nowadays people say legalization with, now some of the psychedelics. But we have to remember that, there was a designer drug crisis and psychedelics were one of the three that were targeted in legislation. Also, if people have been following what's going on in California and psilocybin and mushrooms, there was an aircraft pilot that tried to shut down a plane. And that has halted the legislation in that state from moving forward with great concerns. But all that aside, innovative therapies is the great buzzword right now with psychedelics. If you look over on the right, these are clinical trials. And you can see the gray is psilocybin. Over the last 3-4 years, the number of clinical trials, it's really exponentially increasing. And this is for psychotherapy. It's for trying to rewire, recircuit, rebuild the connections that are good, that are favorable, that lead to, treating substance use disorders, as well as behavioral disorders. So I want to point that out that, this is not a new frontier, it's a renewed frontier. We had LSD trials, 6, 7 decades ago. It's not a new thing, but it's renewed now that we have better ability to do clinical trials, and we have newer drugs that can be used in conjunction with clinical trials. But the bottom line for me moving forward is, can we overcome the challenges that we're going to face? Can we overcome the fact that when you begin to move things into commonplace use, that they also enter it across the board? In other words, casual users will begin to experiment more. And it's something that we have to think of if we're going to advance this new frontier in terms of therapy for many use disorders, right? So with that, I want to move on to our next speaker. And hopefully I've stimulated a few questions because I do love questions. Thank you.
All right. Thank you so much, Dr. Ferguson, for that information. Really important information to have. And I know that a lot of the patients I see are very interested in psychedelics in particular and the effects and benefits they might have. And I would say amongst the physician community, we definitely need to get up to speed on the positive effects it can have and get a little bit more education so we can help our patients. All right, so our next speaker is Dr. Laura Palombi. Dr. Palombi is an associate professor at the College of Pharmacy in Duluth. Her research, service, and public health practice focus on working with rural communities and tribal nations to reduce substance use and prevent opioid overdose. She is a member of the Opioid Advisory Task Force, which is a university system-wide opioid initiative working to advance knowledge of addiction and pain management through basic and translational research, clinical approaches, and policy. Dr. Palombi, welcome. Can you please discuss what substance use disorder is, substance use trends in the United States, and any new or emerging policies and treatments?
Thank you. Well, it's an honor to be here joining all of you tonight. So thank you for having me. We're going to start with what is substance use disorder. So clinicians will look to this document, to the DSM-5. And so I'm going to give you a definition from a textbook to start with, but then we're going to talk about what does it actually mean. So substance use disorder is when someone has patterns of symptoms that are caused by using a substance that they continue taking despite negative effects. So they fall under four main categories. So that would be impaired control, physical dependence, social problems, and risky use. And, before we get into this, I just want to acknowledge that a lot of you joining tonight probably have either struggled with a substance use disorder yourself, or maybe you have a family member that's struggled. Maybe even some of you have been touched very personally by substance use disorders and overdose. So just before I begin and share statistics, just want to acknowledge that all of these statistics we're sharing are actual people, and our heart goes out to you if you've lost a loved one to this crisis. We're all working hard. Dave already shared ways that he's working in the lab. I'm working in the community. All of us are working in different ways to try to make our world a better place and improve this. So as far as trends in the United States, really, we've seen substance use go up. Among people 12 or older in 2021, 20% used illicit drugs in the past year. So when we say illicit, that means drugs that are not prescribed to them. The most commonly used illicit drug was marijuana, but opioids also were very common. 16.5%, so that's a large percentage, met the criteria for a substance use disorder, which I just shared. Somebody who's using drugs despite the consequences. Maybe they're trying to cut back, they can't, they're having these cravings. So it's a lot of folks, right? 29.5 million who are classified as having an alcohol use disorder, and then 24 as a drug use disorder. So this is not just something that is those people. I think there's a lot of stigma around substance use disorder. We have to see these numbers and know this is a lot of people. These are our friends, our neighbors that are struggling. So as far as Minnesota specifically, alcohol is right now the most often used or abused drug in Minnesota. It causes more deaths, injuries, and illness than any other drug. Sometimes we don't think of alcohol when we're talking about drugs, but it is the primary substance used among adults in Minnesota who enter treatment. Followed by that is methamphetamine. I know sometimes people are surprised to hear that because we hear about opioids in the news all the time, but methamphetamine is actually the second leading substance that leads to treatment admissions, followed by injection drug use, heroin, and other opioids. So this is a map. We're not going to go into a lot of detail, but I share this just so you can see how things have changed in the treatment landscape in our state. So on the left is a map of heroin substance use disorder rates in 2007. On the right is the same map, but in 2020. So you can see, we talked about how the opioid crisis started with prescribing, but then a lot of folks turned to heroin. And then the next wave after that is fentanyl. And there's different waves of the opioid crisis. So you can see here all the folks that are entering treatment for heroin. And this was 3 years ago. So the maps are even darker now, but you can kind of get a feel for that. And I think the other thing that this highlights, sometimes those of us living in rural Minnesota, at least myself speaking, used to think that the drug use was something that was from the cities, right? Like, oh, drugs are in the cities, they're not in my backyard. But really, if you take a look at this, St. Louis County, that's where UMD is, where I teach from. Carleton County is where I live. All of these counties are a little darker because we really do struggle with substance use disorder in rural Minnesota. And again, here's the different waves that I talked about of overdose. So opioids are the drug that's most likely to cause overdose because they cause deadly respiratory depression. So the first wave were those prescription opioids. And then, and that was when we were not really looking at the data. that maybe would have told us that people were becoming dependent on opioids. So then we tapered them off their opioids too quickly, again, without looking at data. And unfortunately, a lot of those folks that were dependent on opioids then turned to heroin. So we saw a rise in heroin use. And then after that, we saw fentanyl being introduced into our drug supply. This is fentanyl made in labs. It's not pharmaceutical fentanyl. It's imported and mixed into the drug supply. And then our fourth wave, fentanyl with other stimulants. And now we're seeing more things laced into our drug supply, things like xylazine, which isn't an opioid too. So it's getting to be, if it wasn't dangerous years ago, it's really dangerous now with fentanyl so widely mixed into our drug supply. And it's not just in heroin. Fentanyl has been found in stimulants too. So we have a lot of folks who are at risk of an opioid overdose who don't even know that they're getting an opioid. So really quickly talking about Minnesota specifically, you might be curious if our state follows trends that are across the nation. And you can see here on the left, I have a diagram, opioid involved overdose counts, really mirroring all drug overdose numbers in Minnesota residents. So you can see that the opioid deaths are driving the rest of these. And again, these are our friends and our neighbors. This is really, really heavy for us in Minnesota and everywhere too. I think the other thing that's really, really heavy for me, at least specifically working with rural and tribal communities, is that in Minnesota, our American Indian people are 10 times more likely to suffer from a drug overdose than a white person. We actually lead the nation in the worst disparities for American Indian people when it comes to overdose. And Black Americans as well, 3 times more likely to pass away from a drug overdose than white Minnesotans. So we have an awful lot of work to do in our state in really supporting these folks and these populations and improving health equity and doing a lot better job with harm reduction. So what are some barriers to saving people's lives? I really wanted to share this slide because I want to talk about stigma. We know that about 90% of people with a substance use disorder don't seek treatment, and that's largely because of stigma. The stigma that comes with admitting that you have a problem, with trying to find treatment, with maybe having family or friends or a community that doesn't support recovery. There's something we can all do, and that's think about the language when we talk about substance use disorders and calling them a substance use disorder and a person with a substance use disorder, never an addict or a junkie or a drug seeker, because those are stigmatizing terms that really perpetuate the problem we have. Another barrier is geographical isolation for rural and tribal communities. You saw that map I showed where we have a lot of folks in these communities that are struggling. There's fewer resources for prevention, treatment, recovery, and harm reduction. Also treatment facilities, there's a shortage in rural Minnesota, making that another challenge. Policies often that don't support second chances when people in recovery can't even get a job because of their criminal record. That's really difficult when they spend all that time working on their recovery and then they can't even have that second chance to even try to make a living for their family. And then largely social determinants of health, which is an entire topic in itself. But basically all the different factors that affect somebody's health that have nothing to do with their genetics per se. It's all these different outside factors like economics and geography and opportunity, all of those things. I was asked to talk about policies too, so I just wanted to touch on a few. One that I'm more familiar with. So we had the 2023 One Minnesota budget, which had a lot of money focused for improving health for people with substance use disorder and prevention, treatment, recovery. One that I'm familiar with is a new policy requiring all schools, law enforcement, and emergency responders to have naloxone on hand. So I have done a lot of Narcan trainings for schools, which I love to do. I love that Narcan is in our schools now, and sometimes in our buses. It's very much needed. And really, there was a FDA ruling that naloxone is now, or Narcan is now available over the counter. So that helps as well, I think, with people's fears about a drug, just learning more about it and learning about the safety profile of Narcan. And then also a focus on expanding medication-assisted treatment, new peer recovery support systems, and a new naloxone portal. I just wanted to share, this is a slide from some of the work that I do. We have Some new initiatives. This is a harm reduction vending machine that we just installed at the Boys Fort Band. It's an example of us working creatively with new legislation that now allows things like fentanyl test strips and xylazine test strips. This is the first tribal nation to have a harm reduction vending machine, and I think potentially the first one in Minnesota as well. But this machine has things like Narcan and fentanyl test strips, xylazine test strips, pregnancy tests, HIV tests, all sorts of things that people would need, as well as things like snacks and feminine hygiene products, things that you get from the drugstore. But when you're a really isolated rural community, you just don't have those resources. So this has been really a good opportunity for us to embrace some new policy in our state and do some good for rural and tribal communities. And lastly, cannabis now being legal for folks 21 and older to use and possess in Minnesota, which we will be talking about next with Tracy joining us. As far as treatment resources, just wanted to share some really helpful ones. The Samson National Helpline is really, really great. Confidential, free, 24-hour a day, 365-day a year service. There's a 1-800 number there. I highly recommend that everybody have this number. You never know when you're going to be able to refer somebody, maybe for yourself even, friend or loved one. There's an online treatment locator for someone who's just looking for a treatment bed near them. And then there's also assessments that can be done through local or county public health. So that's another way too. Maybe you don't want to call a phone number or go online. You actually want to talk to a person and do an assessment. That's another way that you can do it, by going through your local county. So with that, I'm going to turn it back to you, Amy.
All right. Thank you so much, Laura. That was such helpful information and such an important topic. We deal with that in the physician community every single day. You're right. It touches so many lives. It can happen to anyone. And I'm glad that you shared some resources. And I really actually liked your harm reduction vending machine. What a creative and innovative solution. So thank you for sharing that. All right, we're going to move on to our next panelist, Dr. Tracy Toomey. Dr. Toomey is a professor in the Division of Epidemiology and Community Health at the School of Public Health. Dr. Toomey is an expert in public health policy with a particular studies assessing and or changing alcohol, cannabis, and tobacco retail environments, and on studies measuring the prevalence, strength, and effects of local and state substance use related policies. Dr. Toomey, welcome. Can you please talk about the potential benefits and concerns around cannabis and alcohol?
Yes, thank you. I'm so happy to be here tonight with all of you to address all these are really important substance use topics. Next slide, please. I have no conflicts to report. Next slide, please. I'm going to start first talking about alcohol. As Laura talked about, it is a very prevalent, it's used very commonly in our society, and we have a long history with alcohol. But a lot of people don't think about the fact that alcohol is associated with many problems, many public health and societal problems. I think when I go out and talk with communities or parents or youth, a lot of times people will say, well, yes, drinking and driving is dangerous. And so people are aware that drinking and driving may result in injuries or deaths. People aren't as aware maybe of the fact that we also have injuries and deaths resulting from falls and boat and snowmobile crashes in Minnesota. We see deaths from drownings. We have complications with pregnancies, unintended pregnancies, increased risk of fights, sexual assaults, homicides, suicides, nonviolent crime like vandalism, school and family problems, progression to other drug use, and chronic diseases like cardiovascular disease for heavy alcohol use, and cancer. And so a lot of my work is trying to prevent those problems. I wanted to highlight just the connection with cancer. Next slide, please, because I think a lot of people are not aware of some of the connections with alcohol and cancer, the associations. We know that the more that people drink, the more at risk they are for certain types of cancer. And that risk may start to be elevated even with very low levels of alcohol use. Looking at 1 to 2 drinks per day. And this includes esophageal cancer and breast cancer. We start to see an elevated risk with even light use of alcohol use, and it increases as people drink more heavily. With moderate to heavy use, we see an increased risk of head and neck cancers as well as colorectal cancers. And with heavy use, we see a increased risk for liver cancer. Next slide, please. Now, I gave you a long list of potential risks with alcohol use. There are some potential benefits. I oftentimes hear people say, well, I'm going to drink because it's heart healthy. Well, I'll tell you, part of the reason you've heard that message is the alcohol industry has latched onto that and promoted that message. As a researcher in the field, there's ongoing debate about, what are the potential cardiovascular benefits. I was for today reading through some of the literature, and it may be that it's some lower levels of alcohol use that may give you some benefits. But again, if you drink more heavily, there's cardiovascular risks as well. As I was again preparing for today, I saw that there could be some protective effects or benefits in terms of alcohol use in certain types of cancer, like kidney cancer and non-Hodgkin lymphoma, but I don't know how strong that literature is. So I wouldn't start drinking alcohol to prevent those types of cancers from occurring. And then I'd just like to acknowledge that as a society, we have decided that alcohol is beneficial to people from a social perspective, for relaxation. And I'm not going to dismiss those. I'm not advocating for prohibition of alcohol. It's just being aware that there are risks, and we often are talking about trying to control some of those risks. Next slide, please. The 2020 to 2025 dietary guidelines for Americans is that we drink in moderation. If you choose to drink, that for women, the recommendation is no more than 1 drink per day. For men, no more than 2 drinks per day. And there is no recommendation out there to start drinking if you don't currently drink alcohol. Don't start it for health benefits. Next slide, please. And when we talk about 1 or 2 drinks a day, it's really important to think about what is a standard drink size. And I've listed a few examples of standard drink sizes. If you're drinking a beer and it's at a German restaurant and it's a boot, or if it's, this big, that's probably not just 1 drink. That's probably a couple or more drinks just in that 1 container. So it's really important to understand how much you're drinking and how it fits in with those guidelines. Next slide, please. We also have very strong recommendations of who should not drink alcohol. This includes people who are under the age of 21, who are at particular risk of alcohol-related problems, people who are pregnant, might be pregnant or trying to get pregnant because there are risks to the pregnancy. There may increase the risk of stillborn births. And if the child is born, there might be the risk of alcohol use disorders there's a risk to the child that's exposed in utero. And people who are using medications that may interact with alcohol need to be careful. And people who have medical conditions that could be made worse by consuming alcohol should not consume, as well as those who are recovering from an alcohol use disorder. Next slide, please. So that was a really quick overview of some of the health and potential benefits of alcohol use. I now want to switch and talk about cannabis or marijuana use. This is a rapidly changing research field and field in practice and health field. It's rapidly changing because the policy landscape is changing very quickly across the United States as well as in other countries. The products that people are using that are being sold across our states is changing, and how people are using and consuming those products is changing. And as a result of all these things, it's really an emerging research field, and it's a very large field. I will be upfront. It's a field that I am learning, and there is no way that everyone can know everything about cannabis at the moment. And part of that is that because it's an emerging research field, there's much that we don't know. And there are barriers to doing some of the research that we need to do, some challenges. And so there are things that we still need to answer. Where we can do research, I will be upfront that there's lack of consistency across those research studies. People say, well, our traffic crash is going to go up in Minnesota. I can't give you a clear answer. Some of the research suggests that it might, and some of the research suggests that traffic crashes won't go up. Now, I know that's frustrating to a lot of people, but I'll tell you, in an emerging field in the early days of research, it's not surprising to see inconsistencies. As we do more research, we start to have clearer recommendations, clearer answers. So those recommendations that you might see today may change next year or the following year, and our answers are likely to change as we learn more. Next slide, please. Minnesota has changed the cannabis policies quite a bit in the past 10 years. In 2014, Minnesota legalized medical marijuana use and approved medical marijuana use for some conditions, medical conditions. That list has continued to expand over the years. In 2018, the federal farm bill essentially legalized low potency hemp-derived THC cannabis products. Those are the products that many of us are seeing at places like Patina or people have seen it in hardware stores, and now it's showing up in liquor stores. Many different places are selling these beverages and gummies in our state. In 2022, the Minnesota legislature placed some controls on those hemp-derived THC cannabis products. So some people thought that was when it was legalized. Well, it was actually legalized in 2018, but our state actually recognized that we needed to put some controls on it. Other states have no controls. So saying that it's illegal for someone under the age of 21 to consume or to sell those products to someone that's under the age of 21, limiting the packaging size and the dose levels. Now, move forward to 2023, Minnesota became the 23rd state to legalize cannabis for adult non-medical use. And Minnesota is currently setting up the regulatory system. So there's a new state agency being developed called the Office of Cannabis Management, and they will be setting up a licensing system. And at that time, we'll start to see dispensaries being opening up in Minnesota sometime in the next year to 2 years, and they'll be starting to sell the more high potency products. Currently in Minnesota, some tribal nations have already moved forward and selling some of those products on tribal land because they fall under different policy. Next slide, please. We know that there are risks for underage youth that I want to emphasize, that there's concerns with brain development that can harm thinking, learning, and memory skills following cannabis use. There are more studies that are needed to fully understand the effects on brain development. The younger people are when they start to use cannabis, the more likely they are to develop a cannabis use disorder. There's some concerns about some youth who use cannabis may progress and develop mental health issues, may progress to other substance use. And then there's real concern about young children who may stumble across something that looks like candy, the gummies, the candy bars in some states, and they may consume too much and they are ending up in the ER as a result. Next slide, please. And in terms of risk related to adult use, there's some things that are starting to show some consistency, potentially worsening of schizophrenia symptoms. If people use during pregnancy, it may result in lower birth weight of the infant. If cannabis is used during pregnancy and while nursing, it may affect the brain development of the fetus or the baby. Some people experience breathing problems. It can irritate the lungs, similar to tobacco use. Some experience increased heart rate and may increase the risk of a heart attack, especially among those that may already have some cardiovascular disease. Even among adults, more frequent use may increase the risk of cannabis use disorders. And then some people are experiencing, after regular long-term use, a development of a syndrome that may result in regular cycles of severe nausea and vomiting. Next slide, please. Now, there are some potential health benefits that have been identified for cannabis for adults. For some people, it may reduce chronic pain, at least some with using some forms of cannabis. Some studies have shown that some forms of oral cannabis derived medicine can reduce chemotherapy-induced nausea and vomiting. Some patients report improvements in spasticity symptoms caused by multiple sclerosis. And for some people with some medical conditions, there's studies that have suggested that cannabis may improve sleep for people with those conditions. Next slide, please. Bottom line is, because this is an emerging area, there's an expansion of use of new types of cannabis products, and more people are starting to use this product. I would urge people to be cautious. There are many health claims. Sometimes industries that produce these products, including alcohol, by the way, will make very strong statements. If one study comes out and suggests a health benefit, it may or may not be true health claim. Same with, there's some people that are saying that cannabis is going to cause a lot of health problems. May or may not be backed up by research. So we really need to give time for the researchers to really identify those health benefits and those health risks. Also recognize that the benefits and risks may vary by the type of product that you're using. There's no agreed upon. Serving size is another issue. And then understand the products that you're using. So for example, if you're smoking it, you may start to feel the high sooner, and that high may dissipate more quickly or disappear more quickly. If you're eating an edible, just know that that high may not show up for 30 minutes to an hour. So what's happening is sometimes people don't feel it because it's going through the digestive system, and then they think, oh, I need to consume more, and then they may overconsume, and that may result in a problem. So just use caution and educate yourself and talk with your physicians, and do some of your own research as you're using the products. Next slide, please. There are a couple resources I want to highlight. The alcohol epidemiology program is, I've directed that for a number of years. We really do focus on prevention of alcohol-related problems. We have a website and some resources. This summer, the legislature started funding the development of a cannabis research center in the School of Public Health. We're still developing it and hope to launch it next month. And we'll have a website and hope to offer some resources for people through that center as well. Next slide. With that, I'll hand it back to you, Amy. Thank you so much, everyone.
Hey, thank you so much, Dr. Toomey, for your expertise and knowledge. Such an important topic, and I'm glad you shared all of that with us. We're now going to move on to the question and answer portion of our discussion. You can submit your questions anytime for our participants using the Q&A button, which is located at the bottom of your Zoom screen. And with that, our first question will be for Dr. Dave Ferguson. Our participant says, I was born in the 60s and marijuana has been illegal my whole life, leading me to have a negative view of marijuana use, even now that there are legal ways to use it. Is this a completely wrong attitude that I should just try to get rid of altogether, or is there still something to it?
Wow. I mean, I have to say, wow. I mean, I think that's definitely a cultural based question, and one that we do love to tackle with students and many people contributing to that. I think we are who we are, but the facts are that the benefits, I think, of cannabis in terms of potential treatment and good are probably outweigh the negatives. And, also I'm a sort of a child of the 60s as well. And I had those same opinions of it, but I think through science, I overcame that bias. And, I've embraced the fact that if we're going to make headway, we're going to have to change the way we view it and destigmatize it and bring it forward. I noticed someone else asked about barriers to cannabis research. And as someone that has a volcano in my lab that we look at the entourage effect with cannabis and hemp, it is very difficult to get dollars from the federal government very easily. And it's also very difficult to find competitive journals to produce and publish validated materials. So these things have to change. And I think we all have to change. And of course, change can be great and good. So it's a really difficult question. I really appreciate it, though. It makes me feel good to hear a question like that people are thinking that way. Right? That means we're changing. We're embracing it. Thank you.
Absolutely. Thank you so much for that perspective. Very important. All right. This next question is for Dr. Laura Palombi. Are opioids still used regularly in medical, surgical situations as intended, or are physicians shying away from their use?
Oh, I think the answer is both. but yes, they're definitely still used. There's, if anyone's interested in learning more about opioid prescribing, the CDC did put out a new prescribing guidelines set in 2022 that really expands and gives more specifics to how opioids should be prescribed, not just for chronic pain, but for acute pain. And so definitely opioids still have a very important place in medicine. That is definitely true. Our physicians and prescribers more cautious? Yes, I think so. Without being a prescriber myself, I think I can say that they are. And with rightly so. We know that as a medical community, all of us really have a role to play in the opioid crisis. I think prescribers and maybe not looking at strong enough data, and pharmacists and filling all these prescriptions without really speaking up to talk about the trends that they were seeing too. So I think all of us recognize that we have this role and we're all trying to do better. And our organizations are trying to help us with improved guidelines.
Absolutely. I can, as a physician who has prescribed opioids over my career, I can also input that when I was an intern in the emergency room many, many years ago, 15 years ago, we would prescribe 30 pills of Vicodin for a fracture without a second thought, or without hardly any counseling for the patient. And that has changed dramatically. I would say physicians are a lot more careful about not prescribing as much narcotics. They certainly are important in certain situations, but we are trying to adhere to more rigorous guidelines and prescribing shorter courses for shorter amounts of time. Another thing that I think is also beneficial are non-pharmacological options for pain management. These can take a little bit more work, but these are really important things like physical therapy, biofeedback, acupuncture. There's a lot of other things that actually do potentially have some benefit, and I think that also needs more attention as well. All right, we'll move on to our next question. This is for Dr. Tracy Toomey. What is the increased risk for cancer related? I'm guessing probably related to alcohol. 10% higher, 50% higher, etc.
I actually don't have those exact numbers, so I'm not going to quote a number. I'll tell you that for the lower, lighter alcohol use, it's a incremental small increase. At a population level, I'm an epidemiologist, so I will tell you I focus a lot on population level risk. And so a small percent increase may result in significant problems for a whole state. That's different than maybe a judgment you're going to have to make about your own drinking, or any individual will have to make about their own drinking. So individually, it's going to be dependent on your genetics. It's going to be dependent on a variety of other factors. But at a population level, we get concerned even if we see a slightly elevated risk, because it will result in population levels of problems.
Yes. All right. Thank you so much for that. Our next question is for Dr. Dave Ferguson. How can psilocybin be used to treat depression?
Yeah, so I typed an answer on that, and I think with psilocybin and treatment programs, and Amy, you may be able to weigh in some on this if you've read some in the field, but many clinicians that are using psilocybin are screening patients for pre-existing conditions. And I don't know if there's currently a guideline for screening, and if whether or not, depending on depression and the current diagnosis, if those patients would be eligible for a psilocybin treatment program. So I think the people on that are here listening should realize that this is one of the issues that we have to tackle, and that is, if you have a pre-existing condition, who's going to make the decision whether or not you're eligible to try psilocybin as a therapy? And I know that in certain conditions, bipolar, the outcomes were not good. I know that there were difficulties, and they're not usually recommended for treatment. With depression, though, I think the data has shown that the outcomes have been pretty good. I know in Alzheimer's patients, there's some long-term studies, and in patients with Alzheimer's and dementia, their moods are better over long-term, treatment. So I think that the outcomes for depression have been reasonable. But we're really talking about, the beginnings of this, and writing policy and trying to create good change that won't come back to kill this movement, right, in the next 5 to 10 years. So I don't know if that helped answer the question, but I think it's a little more detailed than I could probably answer, given that, there's
drinks in a row at one time. Now you talked over spreading it out over multiple hours, and that might be safe. But when people drink, some people say, oh, 1 to 2 drinks per day on average. So they'll say, well, I drink 2 days a week, but I drink, 5 drinks on each setting. Well, the more that you drink at one time, the more risk you have of experiencing a traffic crash or some other type of alcohol-related problem. And so when you think about that, 1 to 2 drinks per day, the recommendation really is no more than 1 or 2 drinks per day, not on average. And if you're drinking more than that, you just think about how you're going to do it as safely as you can. Don't get behind the wheel, and make sure that you have various protections in place.
Okay. And I have to throw in that if you are drinking alcohol, the health benefits are most consistent with red wine as probably the most beneficial. But again, stick to those guidelines and don't start drinking just to achieve those health benefits. Absolutely. But if you are going to drink, red wine is probably the healthiest that you can do. All right. So our next question is for Dr. Dave Ferguson. Is it possible to use mushroom therapy to end alcohol addiction?
Oh, so I don't know if I'm the right one to answer that, though, because I think that's where one of the great growths has been, right, is in all substance use disorder treatments with psilocybin, with mushrooms. So, I think there are many people that self-medicate, that microdose, that try to treat their own disorders, both behavioral as well as psychological disorder, using psilocybin. So I do think that's one of the target areas that's leading the charge in terms of therapy value for mushrooms.
Okay.
Remember, just that, and remember that the idea is you're restructuring the circuitry through, right, this change, right, through this modification, this behavioral modification through the serotonergic system. So that's the idea, is you could restructure the system is the idea. Yes, thanks.
Okay, great. Thank you. All right, this next question is for Dr. Laura. Can you please discuss why you think we're seeing higher and more dangerous trends in substance use disorder?
I think that the danger right now is fentanyl in our drug supply, and that we have folks who are at risk of an overdose that weren't 10 years ago. So somebody who is a methamphetamine user or a cocaine user, for example, those are stimulants. Even those folks are at risk of overdose because fentanyl is largely laced in every drug of abuse on the street. So somebody is maybe thinking they're getting methamphetamine or cocaine, and there's fentanyl in it in large quantities. We also have counterfeit pills that are being made and sold to youth too, by the way, unfortunately through social media like Snapchat. There's a DA advisory that was put out on that probably like a year and a half ago. But what's happening is you can purchase pill presses online off the internet, and you can just create a pill that looks like any pharmaceutical. And so you, if you're a person who maybe is dependent on pharmaceutical opioids, you might purchase what you think are pharmaceutical opioids off the street, but those are illicit counterfeit pills, and they very, very often have fentanyl in them. So again, we just have a lot of people that maybe were just dabbling in substances, and now it's become far more risky. They don't have to have a substance use disorder to experience an overdose. They just have to try something, and it has to be, if it's laced with fentanyl, which Dave talked about, extremely potent. Just a small quantity can be deadly. I think the other thing that we mentioned briefly, there were a few questions about xylazine. So xylazine is an alpha-2 agonist. It is not the same as an opioid, not the same as fentanyl, but it also causes deadly respiratory depression. So we now know that xylazine has also been laced in our drug supply, probably for a number of years without us knowing it because we weren't testing for it. Xylazine is a veterinary sedative. It can also be purchased off the internet, gets imported easily and mixed into our drug supply. And again, when you put an opioid, which causes sedation, along with xylazine, which causes sedation, those additive sedative effects are extremely deadly. So I think what we're seeing, those different drivers of the opioid crisis, but we're seeing most recently is fentanyl and then other, excipients that are mixed in, such as xylazine. And I think largely it's just substance use is much more dangerous than it used to be. You could maybe dabble in drugs and try them years ago. And now that's become very dangerous. Again, the importance of naloxone. I think the other thing that we saw after COVID just deserves some mention too is when COVID happened, that social isolation was really, really harmful for substance use. We had people that were solid in their recovery and they lost their social supports when COVID happened and they started to relapse because they'd lost what was keeping them in sobriety. We had people that maybe just used substances occasionally that started using more. And we had people that had never used substances that started using. So that's another piece I think that we're still struggling with.
Okay, thank you so much. And I'm afraid we're probably out of time to answer any other questions. But we want to thank our panelists for their time, their knowledge, and their expertise. And then you, our audience, for participating tonight. It's been great to have you. And we hope that you'll join us next week for our third mini medical session, which will be at the same time next Wednesday, and where we'll discuss different diets, processed foods, nutrition and disease, vitamins, and supplements. We'll have another really wonderful and experienced panel of experts who will answer your questions as a consumer as to how to ascertain what is a high quality food and beverage. Thank you so much and have a great night.